So, welcome back to another edition of the Heart to Heart podcast. And my guest today is returning guest, Dr. Ira Price. So, Dr. Price is an emergency room physician in Ontario, and that's why I want to chat with him today. I want to know, what the hell is going on with the Ontario hospitals. So, Ira, welcome to the show, brother.
Thank you very much. Thanks for having me, Mike. How are you doing?
Yeah,
You're a family doc. You should know. You
yeah,
refusing to
that's
see
true.
your patients
I
too?
mean, I'm not refusing to see him. I just saw some patients at a walk-in clinic. Still got my own clinic going too. So, working hard 5 days a week, doing my thing.
That's good. A lot of them are refusing to see
Yeah,
their patients. That's a
are they
little
still?
weird. I'm telling you, the state of healthcare is it's just so unfortunate right now. Uh, and it's so like there's so many reasons why. I don't want to blame family doctors and say they all, you're all just neglecting to do your duty. And yeah, I said duty, and because I'm five. But no, but seriously, sorry, sidetrack. I worked nights for the last 3 nights, so I woke up to do this, and so my brain is still. I've got squirrel brain at the moment, and
Okay.
so anytime I get a thought in my head, and if it was going another way, it's just gonna go there. But sorry, back to your question. The state of healthcare, it's just I don't want to simply just blame family doctors, right, for not seeing their patient. But what we're seeing right now in our emergency departments, I would say across the country. I thought it was Ontario that was and Ontario might be the worst, and there are some other provinces that have issues, maybe not as bad as ours. But I'll say I have a lot of friends in the emergency departments who work in emergency departments in other provinces, and they're seeing this unprecedented movement as well by family docs. It's not all of them. There are some really amazing family doctors that see their patients in person, but a
Thank
lot
you,
of
Ira. Appreciate that.
yeah, there's there are is that an asshole thing of me to say? Sorry, is
No,
it
keep
okay?
going, keep going,
Okay.
keep going.
No, I don't
Keep
mean it
going.
in a bad way. Maybe
Yeah.
I do. I am judging them. I'm sorry. I am judging the family doctor that is refusing to see their patient in person. And I would say 8 out of 10 of the patients that I see in the emergency department that come in with viral symptoms are there because they either can't get into their family doctor, or their family doctor is refusing to see them in person because they have one symptom of a virus.
Yeah, that's insane.
How does that
That's
make sense?
insane.
And let me ask you this: did the college, and yeah, I'll get back to your question, throughout, but did the college or a family physician say that it's okay in Ontario, let's say, because that's where you work, say that it's okay not to see your patients in person to do a physical examination? Did they say that in COVID, like right now with COVID or because of flus, or let's say not 2 years ago, but at the moment we are right now? Are they saying you don't have to see your patients? Did they send you that information?
I didn't get that information, but I think it may be still up to our discretion. And I do know that they are changing some of the telemedicine codes.
They just did
Yeah, I think
yesterday.
it's effective, effective today or something like that.
Yeah.
So I think that may encourage some family doctors to see their patients in person again, but I think it's crazy. I mean, I've been seeing my patients in person for I don't know how long. I mean, I basically almost never had it shut down for patients. I always said you can come in person if you want to. I give patients the option. You can do telemedicine or you can come in person. I mean, the walk-in I work in that I work at, obviously that's all in person. My clinic, ready to go clinic, that's more of like I do family medicine stuff, but it's mostly like a mental health based clinics where people get cannabis or ketamine. So it's not as essential
So
when it's required to do a physical exam.
let me
But
ask you about your family doctor. Wow, you got me good. Now I got heated all of a sudden, just right away. Fuck. I'm trying not to, but I'm telling you, it's frustrating. So let me ask you then. So you work in a walk-in clinic
yeah,
because I'm going to add one group of people Now, to
Okay.
my list of family doctors not seeing patients, because not seeing patients in person with viral symptoms. They'll still see patients in person with other things, but not if you have a virus during flu season. Like when else are you going to see the flu during flu season? Walk-in clinics are doing the same thing. Walk-in
Are they
clinics,
really?
yeah, walk-in clinics in our area are refusing to see patients because they have viral symptoms. So they'll
Okay.
do, a lot of them will do an online virtual exam. And for a lot of things like cannabis or ketamine, or if you have an ongoing relationship with a patient and they have a chronic disease, sorry, you may be hearing my dog in the background. She can't settle. It's fine. But if you're during flu season, you got to listen to the lungs. You have to. Like that's like if you're gonna do anything, you got to look in an ear and you got to listen to lungs, and maybe a throat if it's a sore throat. Most of the time, it's fine, whatever. But they're refusing to do it. So where do these people go? They've got nowhere to go. I don't blame them for showing up to the emergency department. They're not physicians. They don't know. They think they're all dying. Literally, like they'll come in and be like, I'll be like, yeah, and it's five like the same spiel to all of them. For the most part, I'm like, yeah, it totally sucks. I've been there, and there's not a whole lot to do. Tylenol, Advil, do the vitamin D, zinc, elderberry stuff, or whatever it is. Just symptomatic control. It's gonna suck for maybe 2-3 weeks. And they're like, no, it can't be. I'm dying. I'm the only person in the world that feels like this. It can't be true. And so for them, it's real. For those
Yeah.
patients, it's real. They're dying. So I don't, even though they're not, they believe they are. Therefore, they have to come. They need to go to their family doctors, but they're refusing to see them. And it's driving me absolutely mad. And what it's doing is causing an unprecedented overcrowding of emergency departments, to the point where emerges and hospitals are getting bulletins that are stating, because the pediatric departments are so busy, we're going to start seeing pediatrics in adults and admitting them to adult hospitals if they're like, let's say, over 16. And and I mean, yes, it's multifactorial. Yes, we have like a lot of flu. We've always had a lot of flu. We've been overwhelmed in our emergency departments by capacity. Sorry, I went off. Say like since
No, you
like
need to. I think people need to hear this. I mean, the family doctor is just getting too soft. Like they need to do the job. Like your job
yes,
is to see sick people. So
yes,
like it's insane that someone is sick and then they're gonna say, "Oh, I'm not gonna see this person because they're sick." I mean, how can you call yourself a doctor if you're not willing to see a sick person,
I don't know.
you know, in person? Like it's crazy,
It's not
So
all of them. It's not, and I would say like, 25% of the family doctors are just amazing. Like that is your first line of therapy, and there are some super amazing docs. Like and in rural places, they'll even come in and see their patients in the departments. Like there are
yeah.
some really amazing docs, but for the most part, right now, I don't know what, and maybe it's because these patients are rostered. So rostered patients, as you know,
That's what
you,
it is. See, I'm not part of a foe. I'm
if you're
not part of
part,
foe. So for
right,
people listening, like, you know, I, basically we have to talk about, remuneration here, but that's how doctors, a lot of them in Ontario get paid, is they just have rostered patients. So as long as that patient's on the roster, they get paid a certain amount a month. That's not how it works for me. I have to go into work to get remunerated for work. But I enjoy going into work. Like I want to go into work. I enjoy seeing patients in person. Like I said, I still give, patients the option to call me by telephone if they want to do that, but I give everyone the option of seeing me in person. But it's crazy that there's so many doctors doing it. I think too they're kind of like milking it a little bit. Like I think they've kind of gotten used to this and they're spoiled with not seeing patients in person. And they're used to basically just calling patients on the phone, maybe having a little bit of a shorter conversation, a shorter visit, not having to put their hands on anyone, not having to, maybe expose yourself to someone who is sick. But like that's all part of the job. Like
Yes.
it's like a firefighter saying like, I want to be a firefighter, but I don't want to go to
So
any
yeah,
fires.
no,
Like it's
well, hey,
crazy,
I mean, do
you
they?
know?
But I mean, how many fires do we have, really? But
Yeah,
no, but I don't mean that. That's what I mean, really.
now
But
you're
yes,
shitting on firefighters. Now you're gonna get real
I'm
big
not.
trouble.
They're
I'm
amazing.
only kidding.
Honestly,
I'm
they've
only
been to
kidding.
my house
I know what you
twice.
meant. I know what you meant. I
They've
know what
been
you
to
meant.
my house twice in the last month when I've tried cooking, both times, and so it hasn't worked out. That's in my favor, but they're awesome. He taught me. Well, one of them taught me how to roll the pizza dough I was trying to do, and anyway, it was pretty cool. The firefighters are awesome. But yeah,
So
hold on. But back to this. But that's because you're a good physician, and just to expand on this roster thing, so people have like a super clear idea. In Ontario, you're allowed up to, let's say, 2,000 patients that you can put onto a list. On that list, you will get paid whether you see that patient or don't for the year. Well, if you don't see them, doesn't matter. You're still getting paid. If you do see them, you're getting paid. Same amount. So their incentive to see them is minimal. I'm not saying rosters aren't a good idea for family doctors, and I'm not a family doctor, so I don't want to claim to say that their job is easy. It's not. Actually, I think family medicine is probably one of the most difficult and most important specialties that there is. I'll call it a specialty because family practice is a specialty, and it is like the gateway to all of medicine. And so maybe residency should be a little bit longer. I don't know, but the fact that people are maybe taking advantage of that, or they're saying, I saw one person say, I don't want to see I can't see patients with viral illnesses in person because, we have to do cancer screening, and we have to do, autoimmune diseases, and these people are in the waiting room. How many fucking cancer screenings are you doing in a day? Like, come on, you're saying because the majority of your clinic is cancer screening? Like, that's bullshit.
yeah,
That,
I
to me,
agree.
that's just a cop out to not see patients because you don't want to get sick. I get it, you don't want to get sick. Universal precautions. We've been doing universal precautions for the last 100 years. You can put gloves on, you can wear a mask if you want. And this isn't, I'm not talking about COVID, man. I'm saying just wear a mask in general when you see a sick patient. We've been doing that for 100 years.
Yeah.
You can do precautions in that setting that will keep you or minimize your risk. I see patients all day. So let's say my night shift, I'm seeing, let's say, on average 30 to 40 patients a night in the emergency department. 75% of those people are viruses. And of those viruses, I may have to admit one of those patients, one pediatric, maybe one adult, out of all of that. All right. And most of those people can go. And I walk into the room, I have a mask on. I have to listen to their lungs. I got to do. So what makes you different than me? We're the same
Yes.
person. We went into medicine to treat. You're a good physician. You want to
No,
see
it's
patients.
it's it's true though. It's like, you know, let the emergency
Not
room
angry.
guys deal with it. You right?
Right.
Which is fucking crazy and also
It's crazy.
selfish and detrimental to people's health and to the entire healthcare system.
Yeah.
Also, I'm glad that you brought that up. I didn't know that was, I knew it was part of the reason, but I didn't really think about it too much as to why, the emergency rooms were so overfilled. And part of it is because, physicians just
Part
aren't
of it,
seeing their
most
patients
of it,
in person.
most of it. We're dealing with a virus now. It's flu
Yeah.
season. We got the flu season early. I mean, multifactorial reason. We've been inside for many years. It's come out in a flurry of hail of strikes, and so
And
it's
it's
all over.
influenza and RSV, right? That you're
Yeah,
seeing?
I listen. We test for, when we do testing for, like, when we do nasal testing for viruses, there's multiple viruses. We're seeing a lot of influenza A, a lot of RSV. I've seen metapneumovirus. I've seen adenovirus. There are so many viruses that we can see. Influenza A just sucks. Like, you're gonna have, like, I was thanking my stars when I got COVID because I didn't want to, again for the fourth time, because I didn't want to have influenza. Like, influenza knocks you down for weeks on end, and it's always been worse for me. And so, yeah, but these have been around forever. And that's really what we're seeing a lot of now, and it's hitting the kids. It really, I mean, kids are back at school, kids have been home for so long, and
Yeah.
it makes it really difficult, which brings me to another point. Kay, you could talk about your points, but
No, but you know what though, that's a good point though too that you brought up about the kids, just because I know there was a study that came out last year, or someone did some epidemiological study on some kids, and they indicated that they do much worse with influenza than they do with COVID. So,
yeah.
would it be fair to say, Ira, that kids are getting it worse right now as they were, say, during the COVID epidemic, because kids are being more affected by the viruses you just mentioned, influenza A, RSV, than as opposed to COVID, right? So it seems like, COVID affected adults, much worse than affected kids. But now we have influenza and these other viruses. It seems like
Not
kids
now. Let me correct that. We're just having like an influx of it.
Okay.
We are not used. So hindsight bias. We tend to forget the past, out of sight, out of mind, right? Yeah. And so 2-3 years ago, prior to COVID, we forgot what it was like to be overwhelmed with kids with influenza and RSV and all these things. Because for 2-3 years, pediatric emergency departments weren't full of these at all. I don't need a study to show me that during COVID, kids suffered less. Less flu season. We had no flu season for 2-3 years.
Why is there so much of it though now? Like, why is it not just a regular flu season? Like, why is this?
Well, the question is it a regular flu season that we're just not used to seeing? We don't remember what it's like. I will say that I am probably seeing about 25% more. I used to say, even in an adult emerge, I work both now, it's pediatric and adult, it's a mixed emerge, and I would say I probably see 50-50 of pediatric to adult patients. Prior to that, I probably would only see, let's say, 4 or 5, adults with the flu, and now I'm seeing 15 to 20, coming in. Now, does that mean they all didn't have it then and they just knew how to cope better? And now nobody wants to cope with illness anymore. And as soon as we have illness, the media and others have made us so paranoid that we're all going to die, that people are showing up. And a lot of it is fear-based, because we know they're not going to die. They come in and their lungs sound good. They want to get checked. That's fine. Their vital signs are stable and they're okay. And so, the question is, what is the underlying reason we're seeing it? And is it a fear-based because nobody wants to get sick anymore? And we have an aversion to illness, and not to our fault. I'm not blaming people. This happens in the progress. I wonder what it was like after other pandemics in the world. Were people afraid that they were just going to die from anything? So now we have this post-traumatic stress as like a group, and people are just showing up. In the pediatric population, they're sick. There are some sickos. I have seen, like, the sickest kids that I have seen have had influenza. And the only kids that I see that are sick, actually, like with any viral symptoms, have all been influenza. And there are some of the sickest. I had a kid come in with an oxygen saturation of 48. Yeah, and like I was like inches away from tubes down their throat. Thankfully, they respond to things, but and then kids coming in with oxygen sats of 70%. So like, and kids decompensate. They have these great like they can last really long and do really well. Then all of a sudden they don't do well. It's like I'm good and then I'm not good. Like, definitely.
Yeah.
And so that we're seeing that, but I'm seeing, like, let's say 1 out of 15 of those. The rest should be at least give your first chance to your family doctor to see your patient, to see their patient. But they're saying, no, I'm not going to see them. Sorry, they have a virus. Go to the emergency department. How does that help our situation?
That's not fair to the emergency room docs. And I imagine that you're not the only emergency room doc who's kind of
everyone will tell you the same thing. Every single one will tell you the same thing.
So everyone at the hospital is kind of having this conversation right now, like, what the hell are these family doctors doing? Why are they being so lazy? Why won't they see their patients in person?
Yeah, that's basically the conversation for the viral. So see your patient. Nobody. I mean, some of them will talk about it. A lot of them.
What about What about the nurses? Are they overwhelmed? Are they short staffed? Like what's going on there?
My God, let's not even talk about it. Although, the court just ruled their raise unconstitutional. So that 1% raise they were going to get, so awfully granted by the government in the province of Ontario,
Yeah.
it was rejected in court, which is wonderful. So they do deserve a larger raise. Imagine you are the frontline healthcare provider to, let's say during, let's use Doug Ford as our example. Okay, so Doug Ford, whose mother was elderly during COVID, so all the nursing homes got some really good treatments in the beginning and all this kind of stuff, and down, and they got all the resources were put towards these nursing homes and all these things, and everybody got raises. The PSWs got raises, $3, this and that. Go to the emergency department, go to a care hospital, like acute care hospital, where your OR nurses are working around the clock, because nurses don't want to really work, like can't really work right now because they're so short staffed, and you're getting a 1%, you're getting like a 50-cent raise, 50 cents, and you're seeing the most deathly ill people right now. Like you're literally walking into, I don't know, let's say it's a bacterial meningitis and you could die just walking in the room. Here's your 50-cent raise. It's like a slap in their face.
And they're having to do more work though too, like just because of the
more work.
shortage.
What
Like
we had
on the floor, like isn't it like 1 to 4? I know in ICU, I think it's 1-on-1, or like
it's 1-to-1, 1-to-4, 1-to-8.
Yeah, but and isn't that ratio just completely skewed now?
There was a night that it was 1-to-30. And a nurse refused to work.
And just so people are clear, we're talking about 1 nurse to 30 patients. And ICU
That's right.
Generally 1-to-1 ICU, and different floors.
Emergency departments are having one. Emergency departments sometimes have 1 to 2 nurses working in. Some places they have to close down. This is why we're closing, because you could go. Let's say, hey,
why are they closing? Are they closing because of nursing
shortages? Nursing shortages. And
so that's the main reason why they're closing. I mean,
I don't know the main reason. I know the departments that I know intimately, or I'm familiar with other people who work in them. It's from nursing shortages. You have people that are forced to work in environments that are unsafe, and they call management. Management be like, "Well, you can't leave." I'm like, "Well, I'm not nursing 1-to-30. That's not safe. You got to close an emergency department when that happens." And it's happening. And they're happening in departments around our province all the time, which is why we are forced to close. And it's insane. Now, listen, we'll show up because that's what we do, right? At the end of the day, like for the most part, you've got doctors that want to do their job. We went into this job not to make. You're not going to become rich by just working in an emergency department, unless that's right. And so you're doing this so that you can help people, and we're going to show up and we're going to do the job. But you have to, like, it's like we're doing the job with, like, I call it's like MacGyver medicine. I don't even have a working ultrasound machine, or like, you have a nosebleed, I don't have the right packing for your nose. Like, so I'm literally makeshift. We makeshift resource utilization and allocation. There's so many issues we have with healthcare. We're at a crux. We're at like the crux of the problem. We're right at the point where something has to change. And hold on,
I think it's basically what it is. It's like all of our resources now have been used up. Like we can't really, add anything else, and we have all these patients now who are getting sick. But you were super excited before I interrupted.
So you brought something. Or the money is sitting there and they don't know how to use it, because if they don't use it appropriately, they lose their funding. A lot of funding is based on on performance, or based on utilization for a specific need. So there's money. It's just sitting in the wrong spots, or just sitting and collecting dust until management can figure out how to use it appropriately so that they don't lose government funding. So the way that healthcare works in Canada is that we are publicly funded and privately run. That's how our hospitals work, right? They're private boards. They're not public boards. They're private boards. We have CEOs. We have all that stuff. But the funding comes from the province. So the province gives them the money based on specific, guidelines. And if they don't use that money in a specific way, their hands are tied a little bit too. Then their funding is going to go down and they're going to lose their funding. And so then what do you do? So they make shift and MacGyver what they have to MacGyver, and then the province talks to the feds. The feds doesn't tell you what to do. The province gives a budget, let's say, to the federal government. The federal government gives funding to the province, and the province gets to use the money however they want for healthcare. That's basically how it works. They divide it up to the hospitals, and then if the hospitals, well, we're over capacity, we'll give you some money because you look like you're over capacity. So people like to be over capacity. Sometimes they get more beds, maybe you'll get some more money. Oh, let's have a shortage of nursing staff, but you're a full-time nurse. Listen to this, you're a full-time nurse who works day and night in an emergency department or in a hospital. You're going to get paid X. Let's say it's $45 an hour. But now let's say you put a backpack on and you go travel to some other province as a travel nurse. You're going to get paid $100 an hour for travel nursing. It's crazy. So who wants to work? Nobody wants to work full time in a hospital, because you could go travel nurse and make 3 times the amount of money.
So, okay. So first of all, isn't it usually between about 36 and 42 for nurses? Or is it
something like, no, you're right. Okay. 36,
and
42 as a nurse who's not travel nurse.
But okay, so just explain the travel nurse thing to me. So this exists within Canada. I didn't really know about this. I thought this is more of like a states thing. But
no, it exists here.
So how does that work? Say you're a nurse in Ontario and you want to become a travel nurse. Like,
you put on a backpack and you apply to a different hospital in a different province that it says, hey, we need nurses. Even if their own nurses in that hospital are making like $42 an hour, and you say, I'm a travel nurse and I signed up through this program, so 85
let's say Newfoundland is having trouble, just because that's my home province. I love Newfoundland. Right. So let's just say they're having trouble and some nurses here like, okay, let's go to Newfoundland and make some bank. They're going to go to Newfoundland and make $100 an hour.
85 to 90, something like that. Just cool. Putting on the knapsack. But the other nurses in that department are not.
Okay.
Now, I'm not, again, there's a
we need those nurses though too.
100%.
We're not knocking them. I'm not deserve that money. In fact, they deserve more. That's what we said at the beginning. That's what
they deserve that money every day. Yeah. That's my point. Yeah. My point is every single day. I could never do a job that a nurse does. I tell them every day, like, I might be a little cocky in the department and I like to have fun and all this kind of stuff. And I'm kind of not your typical emerge doc and wear silly socks and I say silly shit and all this kind of stuff. But like, at the end of the day, I look at them and I say, I could never do your job. You couldn't pay me any money in the world. I would fail. I would fail at the job they have to do day in and day out. The amount of patient care, the person that's there every step of the way. I write orders. I do emergency things. The nurses have to do most of the work. We work as a team, but like they're doing the job. And they need to be paid a hell of a lot more money than they're being paid. Excuse me. And management and in different hospitals and provincially, they need to recognize that. Listen, physicians need to be remunerated appropriately as well. It sucks, getting paid $32 to fix somebody's life when they're dying. And you're spending all this time with them. Yeah, it's difficult. People think physicians and everybody make millions of dollars. You have to work really, really, really hard to do all that stuff, as you know. Yes, we are recession proof, and that makes, a job as a physician. We're not broken. I'm not complaining about it all. You can live comfortably as a physician. You're going to work really hard and you're taking a lot of risk. And you've gone to school for a very, very long time. And nurses go to school for 4 years. They can come right out of school and make a good living. Should they make a better living? Yes. But putting a knapsack on and going to a different province doesn't make you a better nurse to get paid that much money. And they should be paying everybody the same.
So coming back to anyway. I want to talk about family physicians and shortages.
Can we talk about amoxicillin?
We can, but hang on. I can definitely talk about that too, because in my walk-in clinic,
and then let's talk about the Liver King.
It was like, yes, we'll talk about him too. Because it was just like last week, the pharmacist came out to me and said, hey, we're running out of children's amoxicillin,
Crazy.
and then there was we had barely anything left. Luckily, we got some more, so I didn't have a patient where I couldn't give them medicine. Like I think there was maybe one or two where he had to do azithromycin suspension, which is like pretty unique, for the most part. Usually use
Or
amoxicillin, but
cefprozil or
yeah. But
Clinda or something.
the one question I did want to ask you though is, do you think that if everybody, got the flu shot, or if 90% of people, or a high percentage of people got the flu shot, would that have prevented some of what's going on right now?
It's interesting. Remember once I told you I sat with the um one of the director of vaccines for a specific pharmaceutical company, and he
Okay.
basically said in March they decide what they think the flu is going to be for that year. So they don't know. None of us know what the flu is going to be before the flu season. We look at other countries and we hope that we get the same flu, and so we create the vaccine, the flu vaccine, or the flu vaccine for a specific strain, a couple strains of the flu. Do we always get it right? No. Can it minimize your symptoms? Yes. And should people get their flu shot? Sure, they should. Do I think it would have decreased the amount of flu that we see? No, not this year. Years to come. Listen, any pandemic, at the beginning, when the first signs of pandemic started, what we were all saying in our emerges, 5 years. You're going to go 3 years of whatever nonsense happened, and then you're going to go 2 years of having everything else come back in the world when everybody was shut down inside, not being around germs, licking pools, all that kind of stuff. And we will come to the other side. Next year's flu season won't be as bad. I don't think. That's just a prediction. I don't think it will. I think we're getting back to our pre-COVID numbers. We have been overcrowded at working at a flu season. We work at 125% capacity for a decade. That's
But
not new.
maybe there's a possibility though that, and again, I'm just speculating, that because we've got hit so hard so early, like flu season, seems to come in like late October, early November. Maybe, January, February, March will not be as bad. Have you guys thought about that, or any reason why that may or may not be true?
Well, who knows? I mean, how many times are you going to get RSV in a season? I've seen kids that get it 2-3 times. Are they going to get the same flu? It'll probably be a much milder flu. I would say flu season is like is a 12-month season now, until
Yeah.
for the next year or two, until we get back into our routine. I think that's what it's going to be like. Honestly, we're I I'm hoping that we start coming out of it now. In the next, even though it hasn't started snowing yet, everybody's has had the flu this year.
Yeah.
How many? You're not going to get influenza more than once a season. I don't think you get some immunity to it after you've had it. Now there are a whole bunch of viruses you can get. Kids, by the way, and this is what I tell parents, kids can get up to 12 to 24 viruses a year. Sometimes they get 2 in a month. That's normal. I've been saying that. Well, not me. This is what the pediatricians, have been saying for 20, 30 years. Kids gonna get sick. Kids get 2 viruses a year. My kid has been sick. They'll say, my kid's been sick for a whole month. Yes. Were they better at all? Yes, they're better for about a week. And they got it again. Okay, they have a different virus. That's just what happens. Now, this influenza, what it's doing to people, like even the same one, they'll get sick for 5 days, fever, cough, chills, all the stuff, get better for like a day, and then the coughing starts. The fever comes back, the coughing starts, and it's like 2 weeks of hell. And unfortunately, that's what it does. And then sometimes it gives you a post-viral cough for like 8 weeks. And that's where everybody starts going on amoxicillin that don't need it.
Yeah.
There's a lot of overprescribing of amoxicillin, of antibiotics in general.
100% there is. And on that note too, I didn't actually see the study. I just saw one tweeted out, but I definitely trust him. There's a guy, William Wallace. He's been on this podcast for. He's not MD, he's a PhD, but he tweeted out a study indicating that the first world study, he said anyway, indicates that taking probiotics alongside antibiotics does seem to be beneficial. And any thoughts on that, or did
Well,
you
I think that makes sense, but I don't know if that's the first study. I think we've known about probiotics for generations. You go to GI, you go to a gastroenterologist, and they'll tell you to take probiotics when you're on an antibiotic. It screws up your gut flora. We know that. I tell everybody to go on a probiotic when they take an antibiotic. Now,
And then
that
when people get this cough, this like post nasal drip, or like this persistent cough after they get bronchitis or a viral illness or whatever, do you give them Ventolin?
do I give Ventolin for do I give Ventolin for postnasal drip? The answer is no.
Okay.
I give Ventolin to people that have wheezy lungs.
Okay.
Do you hear my dog growling? Because I
Not
left.
really. Not
Oh,
really.
okay.
Don't. I haven't heard your dog the whole time, so
Oh, okay.
I think the audio should be fine on this, but I
Okay,
haven't heard your
cool.
dog once.
Yeah. So antibiotics are indicated in bacterial infections, not viral infections. There is some evidence to say that there's some bacterial superimposed on top of a virus and makes you susceptible to bacterial infections. Well, you gotta show that. You've got to have a pneumonia. Most of the people, even if they have pneumonia now, it's viral pneumonia. Antibiotics don't work for viruses. There is some evidence to say that, there is some like evidence that there's bacterial involvement in some of these viruses, but for the most part there is not. And and antibiotics is not indicated for most of these people. Even with ear infections, unless there's a bulging red membrane, if it's
Hmm.
just red, in all likelihood it's just viral and they're going to
Yeah.
get better, and they
Yeah.
don't need an antibiotic. And we're
It's
just
the
trying,
same
we're
with a sore throat. Like you need to see actual like white pus. Like a bit
right,
of a red
pustules, right?
throat doesn't indicate like
No,
an indication for antibiotic. And then the same thing with
violence.
coffee. Like you should have like a fever, and then also like green, yellow phlegm. Like if you're coughing and your phlegm is just white in color, you do not need an antibiotic in that
If you
instance.
have a runny nose and a cough, you probably don't need an antibiotic. That's viral. A bacteria is infecting your lungs, is not giving you a runny nose,
Yeah.
right? It's giving you pneumonia in your lungs. So somebody that comes in and says, "Yeah, I have no symptoms except I got fever and I'm coughing my brains out." Yes, maybe should I listen, and should we listen and figure this is bacteria? But if you have the myalgias, runny nose, headache, viral symptoms, ear pain,
Yeah.
coughing, that's a virus. The antibiotic is not going to help you with that. And
And
my biggest, I published 2 studies on pharyngitis, so on sore throats, back when I
okay.
was a resident and afterwards, in the Journal of Emergency Medicine and in CGM, Canadian Journal of Emergency Medicine, one in McMaster Journal, I think, way back when, talking about pharyngitis. And first of all, even people that have strep are like, you swab and you find strep, there is a percentage, 10% of our population is colonized with strep throat all the time. And so, even in those cases of having a sore throat, they may not need antibiotics. Now, do we do it? Do most of us do it, even in the absence of pustules and anterior lymph nodes and all the other stuff? Most of us do. And and can you go wrong for doing it? No. Is it indicated all the time? No. But a mouthwash, an antiseptic, antipyretic, and and Thailand, or like an analgesic, is going to go just as far for the most part as somebody who's taking an antibiotic. And I think a lot of the antibiotics we're prescribing is not a lot. I don't know the percentage, so I don't want to make a guess, but a lot of the stuff that I see
Definitely too much. But on that note, and I didn't really think we would chat with this, but I think it's actually a
okay.
really good thing to chat about is maybe we can, and I can start with sort of like the over-the-counter remedies for the people who are listening, who are sick, and they accept it, like, okay, like I have virus, but what the hell do I do now if an antibiotic isn't going to help me? So if you have a sore throat, I've used this betadine, this povidone iodine
Yeah.
mouthwash. Seems to be incredibly effective for treating symptoms. You can get it online, you get it at Amazon.
Yeah.
Shoppers. No, I'm not being paid to say any of this, obviously. Then for like a cough, like just your dextromorphin, I think is, at least mildly effective for people, which is mostly in like Robitussin and all these kind of other things. For a nasal congestion, a real runny nose, I like the local ones, like the Dristan stuff that you spray in your nose. I think those seem to be, pretty effective.
Nasonex, you can get it over the
Yeah.
counter.
Yeah, and
Uh,
actually you can get fluticasone over the counter now too
yeah,
for
right.
allergies, which is pretty impressive too. So we went over sore throat, went over cough, went over.
So you know what I use? Like it is prescription, but Tantum. Tantum,
Okay.
it's like that green. It's an antimicrobial, but it also is an anesthetic in it, and a swish and spit. Chlorhexidine, swish and spit. These things are
So
awesome for sore
for
throats,
sore throats. Okay,
viral pharyngitis,
and then also too, just Advil and
Tylenol.
ibuprofen, that can be effective as well. So there are things out there that people. What about the Vicks Vapor Rub? Do you encourage people to use that?
I mean, I tell people, listen, I think it helps. Is there a
Yeah,
study on it that I know? No, but like,
yeah.
does, putting Vicks on your chest or, under your nose a little bit, is that going to hurt you? No, it's really the camphor in it that,
Okay.
has evidence. And there's evidence for camphor in soothing air passages.
And
Um,
eucalyptus oil and that kind of thing too, I think can be.
yeah, listen, these are symptomatic control.
Yeah.
Is it going to treat your flu? No, but is it going to perhaps?
Treat
And there,
yourself.
Tamiflu in influenza. If you start it within 48 hours, it will help. I mean, there's
Okay.
evidence for the use of Tamiflu. It's hard on your gut, but we have antivirals, and I'll tell you, like, when we had H1N1 back in 2017, and when we had flus
Yeah.
before that, 2011, 2013, when we were overwhelmed just like we are now, maybe a little bit more now, but the big game changer for all of those things was Tamiflu. That's when the elderly stopped dying as much. Tamiflu really changed the outbreaks in nursing homes.
So as soon as you get sick, you need it. It has to be within the first 48 hours. Is that right?
Yeah, that's right.
Okay.
For
So
it to
basically,
work the best.
yeah. So basically, and I think what happens for people too is, they get sick and they sort of almost like deny they're sick, or they'll think that it'll go away on its own. But, I'm probably guilty of doing that myself. But
We all are.
I think that if you are sick, the faster you get on it, the better your experience is going to be overall, and probably the quicker that you're going to get better. So, if you are feeling sick, get treated immediately right away.
Or set up a
Doctor who will
flu.
see the
We
person.
should be setting up flu clinics. Like,
Yeah.
here's a walk-in clinic for the flu.
Yeah, we had a
Just if,
COVID clinic. We should have a flu clinic. You're right.
why not? I mean, that would offload a lot of stress off emergency departments, because they
Yeah.
can then triage what goes to the emerge. Even our urgent cares are overwhelmed. 8, 12-hour waits. It's insane. And most of the people, I feel bad. You've waited 4 hours for me to tell you to take Tylenol and Advil. Now, the problem is people will say, hey, we can't get Tylenol and Advil because there's a shortage of it, because a bunch of greedy fucking citizens just stockpile the stuff. And then the news, on the other hand, has made everybody afraid. It's like toilet paper. And so we're all going to go to get toilet. I don't know why the hell toilet paper. Everyone goes to run to get toilet paper. Like, it makes no sense. Like, but now there's a lot of sick kiddos. And so you can use adult Advil or Tylenol, and you can just, chop it up in half. Or depending on what the weight, go on the body weight of your kid. 15 milligrams per kilogram for Tylenol, 10 milligrams per kilogram for Advil. Or even better, you could go to a compounding pharmacy and they can compound it for you.
Yeah, I'm a big fan of compounding pharmacies. We had a few in London that I
They can
really
compound
trusted.
Tylenol or Advil.
Yeah. Yeah. They can compound almost anything. Most of the good compounding pharmacists can.
Yeah.
But one thing I wanted to ask you about too, because a second ago you were talking about setting up flu clinics and that kind of thing.
Thought I was talking about the Liver King.
Yeah, we want to talk about him too. But the family doctor shortage in Canada. So there was a study or something that came out recently. I saw it in CTV News anyway, indicated that about 20% of family doctors in Ontario anyway are going to retire within the next 5 years. And then I've also seen some articles indicating that there's less medical students who want to become family doctors or who are applying to a family medicine residency. And, I'm wondering, why that is in some ways. And I know that when I went through medical school and through residency, and it's terrible to say, and I am not one of these doctors at all, but like when I was in, a student and a resident, like the doctors would say like, yeah, like don't do family medicine, like it's terrible, like you'll hate your life. And I knew that was what I want to do anyway, and I'm still glad I did it. And if I had to do everything all over again, I would do the exact same thing. I would do nutrition as my undergrad, I would do medical school, and then I would do family medicine. I wouldn't change a thing. But that's me. A lot of people I think would change their course. They would have maybe applied to a different specialty. Like, why do you think, I know you're the emerge doctor now, I'm the family doc here, but like, why do you think we have this like shortage, and why do you think there's less students applying to become a family physician as opposed to something else?
So it's a great question. I mean, that's a silly way for me to start an answer. It's a great question, but the why are they becoming? Why is it that we have such a shortage of family docs? Family medicine is a really tough specialty. You are the first line of treatment. I'm going to give you an example of why it is so difficult. We are trying, let's say we want to avoid type 2 diabetes. Type 2 diabetes is avoidable. In most cases, it is avoidable. What do you do to avoid type 2 diabetes?
You exercise and you make sure that your weight is
Right.
low, decent BMI, eat healthy.
Right. So you exercise, you maintain a proper BMI, whatever that's worth, or like lose fat, and eat right. What's easier? Those things are taking a pill. People don't want to do those things. They want somebody else to do it for them. I know it sounds awful, but people rather wait till they have it and take the fucking pill. And that is frustrating. And so family medicine is where all that happens. So I can only imagine the amount of frustration that family doctors have to go through on a daily basis trying to convince their patients to be healthy. Imagine that. And so it is so frustrating and it is so hard. I see it in the emergency department. Doc, you have to save me. Well, I'm not going to save you. You could save yourself and I'll treat your emergency if you have one. But you can go home and diet and exercise.
Yeah,
No.
I can see how, that definitely would be one of the deterrents, is that you have to, essentially try to, coach people in a way. And
It is.
and this is sort of a bit of a unpopular opinion, but I know that the education that we receive as physicians for, nutrition, exercise is
Awful.
it's nothing.
There's
But
nothing.
at the same time, and I know this is going to may surprise some people, I actually don't think if physicians were more educated on that, it would make a lick of the difference.
No, I agree.
Because the thing is that more knowledge does not equal behavior change. And when someone, is eating poorly, not exercising, you need to change their behavior, and giving them a little bit of knowledge, that's not going to do much. People know they shouldn't be eating McDonald's. People know they should be working out every day, or at least, 5 to 6 days a week. They know that already. They're just not doing it. So, increasing knowledge, amongst physicians, I actually don't think that would, make that much change overall. It's got to come from within. It's got to come from, your own motivation. And, and again, I know, a lot of people think that that's, something that should be pointed out, is that, doctors don't have, good education on nutrition. And again, I agree with you. I agree that, we don't get educated on nutrition and on exercise, but I still don't think that knowledge that, would have been generated for these physicians would have generated, better outcomes for their patients, because a lot of the patients know what they're doing wrong already. I mean, you don't need to go to a dietitian if you're eating McDonald's 3 times a day and not working out. You need to stop eating McDonald's and you need to stop working out. You don't need to go to a doctor,
Right.
you don't need to have any specialized knowledge in nutrition or biochemistry in order to
Right.
understand that.
Right.
So yeah, I mean, it is odd why there are, so few people,
It's hard.
applying, but
It's
it's
hard
stunning.
for them. It's hard. It's hard for family medicine. It gets a bad rap. It's a lot. People think they're going to think it's a lot more lucrative to go into. It's multifactorial. Everything always
And the
is. For
specialists do kind of make fun of the family doctors a lot too. I
they
mean,
do.
they do. I mean, they
Yeah.
call us idiots all the time,
Right.
and they think, oh, that's why he's just a family
You're
doctor.
right. There's a lot of
You know?
stigma. There's a lot of stigma. I mean, the only other specialty I could think that has more stigma is ortho. And I should have been an orthopedic surgeon. Hey, I couldn't stand long enough in the OR. I don't have enough attention span to be like, what are we doing now? It's anyway, but
No, I remember though when I was going through one of the orthos was like, he was like, bro, I know 3 procedures. Okay, that's what I do.
that's
Okay,
it. It's
okay.
so true.
The hip
I had a, I
replacements,
had
the
a,
knee
I,
replacements, and one other thing, whatever else he was doing. It's like that's it.
that's it. I had a patient. This is awful. So I mean, they had a knee. They had like a hip revision or something. They sent this poor guy home with like indwelling catheter, no urine output. The guy comes in passing out. Same day, he's like, I can't stand up. He's dehydrated. Like they just, ortho. No, but in all seriousness, it's multifactorial. A lot of it has to do with stigma. A lot of it has to do with patient readiness to change. It's frustrating. It's hard. It's really hard work. I think it's the toughest specialty to be the front line and trying to convince people over and over again. And then the way they're remunerated, yes, it's lucrative. It's very lucrative if you have like a roster patients, and that's what the government's trying to do to increase the family practitioners. But you can also then go and read radiological graphs all day and get paid
Yeah,
twice as much, or you can go and do cataract surgery and get paid 5 times as much.
yeah.
And the lobbyists, we just don't put enough emphasis on the importance of a family doctor in preventative health. It's always about management, disease treatment, and not prevention. But to your point that you said earlier, you can only drag them to the well, and that's the problem with family medicine is you can only drag them to the well, and it must get so frustrating. But what they can do is see their patients, and I
They
that
can do
and
that.
yeah,
They
and I
can do
just
that.
it's tough though. You have 2,000 patients; they want to see you every day, and we live in a country where people believe healthcare is free. So where it's not, I pay 52% tax on personal income. It's crazy.
It's crazy. And then there's personal tax, everything on top of it. I mean, Gad said, I don't know if you follow him, but he basically said, it's more or less like 70% because, you're taxed obviously on your income, but then you're taxed on whatever you purchase.
We buy,
Then you
yeah.
have, property tax and all kinds of taxes. So
Police.
you only have 2 or 3 minutes left.
Okay, yeah.
Talk about Liver King.
Oh, now we get to talk. I mean, how can I talk about Todd? I mean, we can't talk about it. It just sucks, eh? What do you think? I want to know what you think.
I mean, I think it was just insane that anybody thought that this guy was natural. If people don't know who I'm talking about, just put in Liver King in Instagram. You'll see a guy who's clearly juiced to the gills.
Yeah,
And
gills.
and he said that he got his physique from the 9 ancestral tenants. I don't know what the hell the tenants are, but the guy's a complete nut bar. Like he's insane. And they said, I think that he was taking 12 IUs or something a day. He was spending, I think, $12,000 a month just on human growth hormone, or maybe it was his whole steroid package. I don't know if it was, but I think it was something like 12,000 a month just on human growth hormone. So you got to be careful about who you're kind of thinking about here and who you're listening to, because
I think I took a picture of it. of what he
Yeah.
was taking. No, I can't find. I thought I took a picture of it. I don't have it.
It's insane. There's Winstrol in there as well,
Yeah,
which
there's
is
which.
another
Yeah,
anabolic, and there's a bunch of shit in there that he's taken. But that was I learned it first from Derek, More Plates, More Dates. I don't know if you
yeah,
follow that guy. He's
yep.
pretty good dude.
I look. It's interesting because your other guy that you love there, Carnivore MD, who is very.
Hang
There's like
on. I don't like Carnivore
I
MD. I make
know
fun of
that's
him all the time
I know
because
that's what I'm saying. That's what I'm saying.
yeah, yeah.
To be honest, I actually think he's become a little bit more balanced in the last
I think he has changed a little bit.
last 2 months. He's like, you don't have to eat all of this stuff. He's finally like chilling out. But he was best friends with
Yeah.
Weed MD,
Yeah,
with the Liver King, and he just distanced himself. He just did
that's
this
good.
post that said, "Hey, I just found out that Liver King was doing all this was doing the steroids. I'm shocked in awe to hear it, and I'm gonna have to distance myself. Listen, I think there's nothing wrong with testosterone. I think, and I did this post on it. Testosterone replacement's important for people that have a low testosterone. It keeps,
100%.
there's good evidence that it is helpful against disease and insulin resistance,
Cardiovascular
and
disease, yeah.
cardiovascular health, decreasing fat, increasing lean muscle. Didn't really work so well on me, but
And
the
and I think too, what it really does, I know we got to wrap up here in a second,
okay,
but I think what it really does is it gives you the motivation and the energy to do the things that you know that you should be doing it. And maybe we'll come back and chat about this sometime, because that's a little bit of a dilemma. It's like a guy has low T and he's not doing all the right things. So it's like, okay, one option is that you do all the lifestyle things and you get it back up on your own. But then
hard,
what if he doesn't have the motivation to do
right?
that, and then you give him the tea to kind of get him to that place so that he can start doing those things.
That's right.
But anyways, yeah, I hate to do this, Ira, but our hour here is up. Again, tell people where they can find you online and where they can learn more about you.
Best place to find me is my Instagram at Dr. Ira Price. I'm on TikTok now with my
Nice.
horse, and I'm doing all these little horse. I got a horse, that like keeps me sane. It's great. I actually just bought a lariat, which I just learned is the name for a lasso. Like the things you flip over your head. I want to learn how to like flex this fucking lasso. And anyway, so you know what I'm talking
Horse
about,
MD.
right? Horse MD. Yeah, eat the liver of the horse. You could, and it's Dr. Price there as well. But I just want to finish off. I'm not against family doctors. I love them. I think they're the most important specialty there is, and I think I've said that multiple times. I just think it's a shame that a lot of them are not seeing their patients because they have viral symptoms and they're showing up to the emergency department, which is contributing to the overcrowding of those departments.
100% agree with you on that. I think that's a great way to end it. So everyone, thank you so much for listening, and as always, I'll be back again next week.